Welcome to the Functional Neurologic Disorder Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, with a special thanks to Michael Romeo, our production engineer from Australia, and our content curator, Ingrid Hurritzauer from the UK. This week's guest is Samantha Weber. She has a PhD in neuroscience from the University Hospital in Bern, Switzerland, where she worked with Dr. Selma Eibach, and she now holds a position as a postdoctoral researcher. In this discussion, we cover her professional pathway and background to FND research. We define stress and subtyped trauma and think about how this relates to the brain and the body, such as cortisol levels, the HPA axis, amygdala and hippocampal structural integrity and dysfunction. Prevalence factors from another publication she worked on for healthcare workers with FND, specifically as it relates to female predominance and stress. And lastly, translating bench to bedside, great phrase, as it relates to targets for treatments such as emotional and physiological regulatory treatments, as well as evolving available clinical imaging options to identify dysfunction in FND at the patient level. I will caveat that we are engaging in an academic discussion of these topics, and some of these discussions may appear blunt or direct to a patient-centric audience. Also, all views and opinions discussed in this podcast represent those of the host and respective guest, not any position or policy of the Functional Neurologic Disorder Society. And now I bring you my conversation with Dr. Samantha Weber. Okay, so thanks so much for joining us. And I was wondering if you could start by telling us about your academic background, how you arrived at FND, and your career path and the path you're on. That would be great.
Yeah, hi, thanks for inviting me. So, sure. So my background, I studied health science and technology at the Federal Institute of Technology in Zurich in Switzerland. And this is actually a very interdisciplinary field of studies. So we had a lot of biology, chemistry, but also anatomy, physiology, also biomedical engineering. So we had like kind of some insights into all kind of different natural sciences. Additionally, then for my master's, I did a master in neuroscience, as I was like particularly or mostly interested actually in clinical neuroscience. And then during my master's, I started actually with internships on rodent models. So first in Alzheimer's disease and then later also traumatic brain injuries, where I was just conducting all these behavioral studies in the mice and the rats. And it was interesting, but I was not fully satisfied with that kind of research. So as I also had this little technical background, and I always have been fascinated actually about the neuroimaging, I decided to search something like more patient-oriented and also where I can actually apply this technical background of mine. So for the master thesis, then I ended up with a blind application to Professor Selma Eibach's team in Bern, which was actually
blind application.
It was a blind application, yeah.
Oh.
So that's I saw her profile online and I was like, she looked like super sympathic, and I was like, okay, let's give it a try. She does MRI, she has like clinical research.
Perfect.
So yeah, and then I kind of ended up doing my master thesis there, which was a 6 months project initially. And well, 5 years later, I'm still here. So after the master thesis, I had the great opportunity to just continue with the PhD in her lab, where I graduated last December 2022. And yeah, now I'm here, postdoctoral researcher. And yeah, this is basically the summary of how I ended up doing research in FND in my last 5 years. So yeah. And from day one, I think it was like always a very interesting topic, and I really enjoyed it. Well, it's like sad that there isn't much research out yet, but it's also like a great opportunity to just dig into the field and like always find something new, and it's super interesting.
Yes, it's definitely an underdeveloped, understudied field.
Totally.
So anyone who's interested and willing to make a sort of cold call email application is very much needed. Oh, that's wonderful. I love hearing things like that. That's great. Wonderful. So the next piece, I was wondering if maybe you could tell us about part of your publications have looked at, and I know you're interested in things like stress and trauma. So if you could talk about maybe how you define stress and particularly how it relates to FND.
Sure, yes. So I would actually define stress like as a physiological and also psychological response to, for example, perceived threat or life challenges. I guess it's a very complex reaction that like involves also the activation of the body's stress response system, which includes then also eventually the release of stress hormones such as adrenaline or also cortisol. So like also in the context of like this stress and trauma related disorders, I think stress becomes particularly significant when it overwhelms like the individual's ability also to cope, and leading also then to a range of adverse effects also on the mental and also physical health. So, and how do I see it in relation to FND? So I think let's start again at like the very basics, how I first got into FND. And I think even though it's like highly debated, I sometimes really, or to start with, I liked this kind of conversion model of Freud, like as a really beginner of FND, because I think probably I'm just saying that as I never studied psychology, but I quite like the explanation like of that psychological stress can convert into physical symptoms. And that's actually, as I mentioned, just the very first time I got in touch with some explanatory models for FND. And I think I still find it quite interesting, like this idea like of the strong effect that like the brain, emotions, stress and trauma, and like everything what people can sometimes say happens only in your mind can actually have on your body. And I think this should definitely not be neglected. And well, however, nowadays I see it a bit more critical. And I also think that the term stress and trauma should not dogmatically be used like in the context of FND. So kind of circling back also to the fact that stress should actually be considered, of course, as a risk factor, but also more inside of like this multifactorial model that can add to the development of the disorder. But like stress and trauma should definitely not be seen as the requirement for the disorder.
Yeah, exactly. And as you were discussing, I think especially the older models, like a Freudian informed model of stress and manifestation of physical symptoms. I think working with other medical and neurologic conditions, we see that impact all the time on people without FND, right? If someone has Parkinson's disease or epilepsy, and a stressful environment makes those conditions worse, like that is well known. And it's not so much, I agree that it's necessary in order to have the symptoms, but there's no doubt that stress has a very physiological based impact that then interacts with other bodily systems and processes. So more so that maybe if someone was prone to having FND symptoms, stress is a way in which those symptoms might become worse or more prevalent or become propagated or expanded, similar to a whole host of other neurologic and or medical conditions. In my training as a psychologist, I'm trying to think of a condition that is not negatively impacted by stress, a medical condition that is not deleteriously impacted, yes. Right? I mean, it's just, there's such a fundamental impact of stress and environment on how body systems process in this multi-system kind of way between the HPA axis and immune inflammatory axis and brain gut axis. And it's a very complex thing. And what an endeavor to be trying to study it, which is excellent. I'm wondering if you might also talk a bit about how you have subtyped, because how we're talking about it and measuring it matters, and how you've subtyped or think about subtypes of trauma or stress, and how important or unimportant it is to really tease apart what kind of stress or trauma it was, the intensity, frequency, and all those other factors that researchers sort of attempt to characterize and put into boxes. How relevant do you think that is? Is it essential? Is it critical? Is it research important, but from a clinical perspective less? I'm just curious.
No, I think it's like actually very, very important also like how you subtype trauma. And I think like, for example, the classical way of, or also how we started doing it in our studies, is that we subtyped it into like emotional neglect, abuse, physical neglect and abuse, and also the sexual abuse. I think that's like these 5 typical subcategorizations. And I think it's actually a quite accurate approach, but it's probably also more complex in life. I mean, as you said, it also depends on like the duration of the trauma, like the time point when it probably happened. Like, for example, when you're like very young, when you're a child and you're in these developmental phases of the brain, that probably it might have a much stronger influence than when you're actually grown up and you have built some sort of like a stable life. So also, I think that indeed that these subtypes, they're not necessarily mutually exclusive. And also individuals, they may experience multiple types of trauma throughout their lives. So, for example, like a medical trauma could, for example, be equally physically as well as emotionally distressing, or like, for example, when you're like a survivor of some kind of natural disaster. So what is it? Is it like more physical? Is it more emotional? So I guess there is ways of subtyping traumas, but as mentioned, they also like probably overlap quite a lot. And yeah, I think also in terms of the stress regulatory system and as well as like the influence of the brain, there are different approaches on like how we should like work with these subtypes of trauma, I guess. And yeah, especially like regarding the stress axis, as you mentioned, like the HB axis, so the hypothalamus pituitary adrenal axis. So well, in everyday terms, when we encounter like these stressful situations, our body stress response normally gets then, or stress response system gets activated. So that leads, like, for example, to the release of cortisol. And this process then is also regulated by parts of the brain, like the amygdala, the prefrontal cortex, and the hippocampus, which then work together, like to process also this information on potential threats or previous threats. And yeah, well, like under normal circumstances, like once this stressful situation is over, our body has like this built-in mechanisms to just calm down this stress response again, like involving also again the hippocampus and this feedback loop within the HB axis. However, like in this prolonged state of being in high alert for stressors, which is also like observed, particularly when you have like a history of like some sort of traumatic life events, this can become very dysregulated. So the hippocampus that usually helps them to inhibit also like the stress response might somehow lose that ability to do that effectively. So then something happens, like a process that we can call like HB axis sensitization or habituation, for example. So that means that even when the stressor is removed, our body might then struggle actually to turn off like this stress response, and that can lead to like ongoing release of cortisol. For example, also like in these early stages of chronic stress, the stress response system often becomes overly reactive. So what we observe is then that it releases actually much more cortisol than is necessary, and like constantly releases it. However, when this stress then continues, for example, as we talked before about like the duration of a trauma, when it's like an ongoing stressor, the system may then eventually downregulate. So meaning that it can become less sensitive or less responsive actually, and eventually also releases less cortisol than what it should. So we see it's like kind of this very complex interplay between the brain, the stress response, and also like ongoing or previous traumata. So in that case, like trauma and stress can actually have different effects on our body, also like with regards to the time point and developmental period. So another important thing, I guess, is also like that cortisol is also like suggested to have this neurotoxic effect, especially like on brain regions such as the hippocampus or the amygdala. As those regions, they also have like this high density of glucocorticoid receptors. And so this prolonged exposure to cortisol, this can lead, for example, to impaired neurogenesis, inhibition of synaptic plasticity, or like this increased release of glutamate, which then can also disrupt the energy metabolism, can cause oxidative stress, and also cells can undergo cell death. So yeah, so we can see like it has like a whole effect also like, or potential effect like on a healthy brain structure. So, and now to kind of get back also to the beginning on how trauma is related to stress, cortisol, and the brain overall. I guess for now we have to say we don't know exactly yet, but it's clearly that there might be some dysregulatory mechanisms that take place like in this kind of state of chronic stress. Like maybe it's like a combination with a neurotoxic effect due to this prolonged exposure to stress. But I think in that case, and here I think it could also be very important for FND, is that there might be also some predisposing factors. As for example, also like in one of our studies, we could indeed see that there were like smaller brain volumes in the hippocampus and the amygdala, but only in healthy controls where it like corresponded actually to increased levels of cortisol. So it could, for example, relate to some sort of neurotoxicity. And this effect was actually not found in FND patients. So we were thinking that this might also present some sort of a vulnerability to stress, so that then these people might, or these patients, they maybe just develop FND because they have like some sort of maybe different brain structures that can make them more susceptible to like this dysregulation of the stress axis. But I guess it's also very important here that we have to say that, for example, also longitudinal studies would be needed to actually further like disentangle whether such a dysregulation might have preceded the development of FND, or if it's like more a consequence, for example, of being ill, and like this emotional distress that also comes with the disorder. So yeah, in summary, I guess it's like a big interplay between different factors, between trauma, stress, and how you deal with stress and how the body deals with stress. And like what I think is really still very important, not to neglect like all the predisposing factors, or also like environmental factors, like your social environment, and all this like kind of summarized in a more multifactorial model.
Yeah, great. Thank you so much. And to think about this, or maybe bring it up to some of the typical discussions of FND, or the high level discussions of FND that we've had regarding FND as a software issue rather than that hardware issue. I mean, I think most FND providers kind of a little tired of hearing that analogy so far, but it's the most useful one, I think, to help patients understand where we're describing it's not a neurologic insult, but rather a software issue. However, anyone who's worked with the brain knows, hardware and software are the same thing. It's just a question of the scope and scale, right? And especially when you're talking about at a neuroscience level, or a neurobiologic level, where we're not talking about, the hippocampus getting a stroke, but rather cells within the hippocampus maybe undergoing the stress related to excessive cortisol exposure, et cetera. As you were speaking, I was just wondering about potentially then, if there's, and I agree, this underlying vulnerability and risk factors for individuals with FND to display or develop a quote unquote sort of software issue. But then if stress and trauma serves to accelerate or unmask that process, where enough of a buildup of stress or trauma and the associated biological underpinnings of that, cortisol dysregulation, et cetera, creates sort of this wearing away effect of any protective reserve that a person with FND predisposition had, and then it suddenly breaks the threshold, and then FND symptoms might become more prevalent or prominent in that way, versus in stress and trauma for an individual's brain who is not predisposed to FND, they might have different levels of reserve or mechanisms to counteract the same neurobiologic effects of stress. Just what I was thinking as you were discussing that. Now, the other piece, as you were talking about these different pieces, there's two other things. Touch on one first. Did you see there was a recent article, Susanna Pick, it came out earlier this week, actually, it came up on my feed, about unraveling kind of the influences of effective stimulation on functional neurologic symptoms. And essentially it was looking at how patients with FND, forgive me if I completely misquote this article, Susanna, I will happily have you on to discuss it in more accurate detail if needed, if you're listening. But essentially how people with FND appeared to have a bodily response to stress, even when they were not affectively reporting a negative experience, so to speak, which I think gets at the question of alexithymia in FND, the role of emotion awareness in FND, and is emotional awareness necessary in order to have a bodily response to stress or environmental triggers. And I think a lot of the work and models in FND would suggest people can have sort of a dissociated emotional, or not even dissociated, just a lower emotional experience, but still have a very physiological response that's akin to the emotionally driven experience. And I'm wondering if you have any thoughts about that as well. Do you think someone can have a biological stress response without registering the negative emotional valence of that stressor?
I guess so, yeah. I mean, I'm not like totally aware like of the article that you mentioned, but I think it has like a lot to do like also with your own physical awareness, because, for example, like also like how your interoceptive skills and like how mindful you are, I guess, for example, because probably all of us had at some point like moments in life where we were like totally stressed, but we had like this feeling like, okay, at the moment I cannot afford to be stressed, so I have to function, and maybe it goes a bit into that direction. I would say that it's, to some extent, maybe it's like the awareness of like, when is my body stressed, and also like the awareness of how can I calm it down again. While also I think it also depends a bit like on your current environment you're in, because for example, when I recall, for example, my PhD thesis defense, where I just was
minorly
like
stressful events.
Yes, yeah. So I was like super nervous, of course. But I was like, okay, now I really just have to perform, and I mean, for me, it was like a great experience. I really enjoyed like talking about my work and all that. But I guess like in like more negative events in life where you just have like something very stressful, and then you just have to like delete or like not notice this feelings that you have, and can I allow myself to feel stressed, for example. And if you have like this mindfulness skills, or if you are more aware of like how to judge your emotions or how you judge your feelings and your stressful situations, maybe then it helps also better to like deal with it. So it could be also something that I guess to some extent can be trained, or is maybe not necessarily like a trait of a person, but probably there are some people like also like given their development or given their social environment that are just more of it, like more or less vulnerable to these kind of stressful situations than in that case, and that they actually, based on what they have already, can better judge it. But
yeah. Oh, you're bringing up another, making it even more multifactorial in that way, or multivariate in terms of the contribution of it might not only be awareness of emotion to necessary or sufficient to experience the physiological response, but also if even without emotion or with emotion, you are aware of the physiological stress response within the body, right? Of my body's feeling tense, and this is why, and here it is in the environment. And then additionally, combined with more of the biopsychosocial model in the environment, is this temporary? Is this normal? Are there supports to help me downregulate? Do I have something pleasant to look forward to after, where I know my body's going to be downregulated? I think that's a really great way to potentially look at how all of these pieces commonly discussed in FND might interact and create or not create symptoms and potential treatment avenues. Because I think, current treatments focus a bit on mindfulness and emotions and emotional awareness, and then also physiologic awareness. And I've often wondered is if someone's not having a broad emotional experience due to maybe they just have a lower disposition to emotional experience, but same physiological response, other ways to target sort of rebalancing and creating a better level of wellness, or kind of that lower stress model on the body, in spite of any differences in emotional experience or processing. Because I think if you take someone who's not really used to or doesn't have a rich emotional experience and try and teach them to regulate their emotions, but really what they need is to regulate their body, then it's not going to be very effective. Yeah, I love the multifaceted way to look at that piece. And the environment matters, as you said it. I was also wondering on that note, and I think we talked about this briefly, is sort of resiliency in the brain, and if there's any neurobiologic substrates or processes that you've seen or interacted with in your work that seem to suggest resiliency within the brain. I mean, I just came from, you can hear it in all the clinical conferences, eat blueberries and, like walnuts, and try to take a walk, and those create resiliency in the brain. What, from your opinion, are there any factors that you can identify that point to resiliency or promote resiliency?
I guess like I totally agree. Like let's put it like from a macroscopic point of view. I say like there's like or resiliency in a person can be defined by physical but also psychological factors. So it's like what helps you to build like flexibility, also these coping skills to adapt also to stressors. And I guess, as you just mentioned, like this includes like problem solving skills and seeking emotional support, like having like a healthy lifestyle, this mindfulness skills that I just mentioned, and all that, like to recognize emotions. however, like on a more microscopic level, or like how resiliency can translate into the brain, I would say that there are like many concepts that can make brain resilient towards stress also. So I guess two key regions representing here again are like the hippocampus and prefrontal cortex, where, for example, the hippocampus is like crucial also for memory consolidation, emotion regulation. It helps also to judge the situations based on previous experiences in life. So basically, to learn how to react to situations that maybe are similar, like previous situations that you have encountered and that you have managed successfully, while also the prefrontal cortex is important then for the executive functions, like the actual decision making, like how do you react to the situation and how do you regulate the emotions in such a situation. And it also allows them to like flexibly also respond then to the stress. And in that regard, also like molecularly, I guess it's like a very, very strictly regulated interplay between like neurotransmitters, neuroplasticity, and other factors like neurotrophins that can like support the neuronal growth and survival. But on the other hand, also like negative factors that we have seen, that cortisol can be good to regulate your stress, but like too much cortisol is also bad. Or also there are like the inflammatory cytokines that can also appear when you have like this state of chronic stress that can cause certain disbalances in the brain too. So
yeah, great. And that is a great segue into one of the other topics I wanted to pick your brain about too, is related to sort of prevalence rates in FND. And we've touched on them with, higher prevalence rates in trauma, individuals who've experienced trauma, but then also women, so females. And then another publication you were on regarding healthcare workers, which is, I know, sort of something that's been more anecdotally considered across our field. And you were part of a group that actually considered that, how you might think about, is it the exposure to, and in that sample, I believe it was mostly women in the healthcare workers study as well. I think about 70% of that sample that you studied was women. And how you think about that exposure to a healthcare setting might relate to or play into these stress models, or even as you just described, the exposure to various symptoms, or is there some other factor that we're not considering when it comes to this sort of slightly higher prevalence rate for individuals in healthcare settings?
Yeah, I guess like the very interesting part of that study was, so we actually just had like a random sample of like first referrals of patients to the psychosomatic clinic here in the university hospital. And we just compared it to age and gender matched control neurology patients, basically. And so we cannot say that there were more females in the FND cohort, because we had to like age and gender match them to the neurology patients. But clearly what we could see was that there were, as you said, 75% were actually women, so that had FND. And I guess, so also like when we looked a bit at the statistics also of like the healthcare in Switzerland, and for example, it also says that up to 74% of jobs in the healthcare business in Switzerland are actually done by women. So I guess to some extent it's like, for example, like being a nurse or all that. So there's like clearly more female nurses than male nurses, which is, for example, an extremely stressful job, like on an emotional, physical, and also psychological level, as you have like this very strong interaction also with the patients. So you're exposed also to many neurological symptoms too, while it's still like a job with like where you have to work in shifts, and it's like really stressful itself, like not just in terms of the shift work, but as mentioned, so it can be hard also like to be so close to patients and to do a job that is currently still not really well appreciated in comparison to, for example, like being a doctor or something like that. And yeah, I guess this definitely could add as a risk factor, but clearly like there would be more studies needed to actually see if there is actually an association like between like working in a healthcare employment, and if that has actually like really an effect also like on FND itself. But yeah, clearly I guess it might has an influence also regarding females probably also searching rather for health, like for help when they actually have like this kind of psychological or physical symptoms, so that they're more likely actually to seek help from a doctor. And maybe that's why also they rather get diagnosed with FND, or also, for example, as I mentioned, like the historical context, of course. So like FND, like with the whole story on hysteria, it used to be like a disorder that just happens in women. So maybe it could also be that as a woman, you're like more likely to be diagnosed with FND, whereas as a male FND patient, you maybe just would get a similar diagnosis or medically unexplained symptoms, for example. So yeah.
Or to the kind of shell shock diagnosis, where it was very more clearly delineated along a post-traumatic stress response rather than a hysteria kind of conversion. Yeah. And one other part that as you were talking about, women are more likely to represent the bulk of healthcare workers, such as nurses, et cetera. I was also wondering if maybe there might be a shared kernel under there for FND, if there's a predilection for caregiving roles, right? Sort of highly active caregiving roles. And I've just anecdotally heard that from many of my patients. A fair number are nurses or in healthcare roles. But then if they're not, they're seemingly, in other very active jobs, and then engaging in very excessive caretaking roles for their family, where they're the person who does everything for everyone and they're the person everyone comes to. And if that might be an interesting underlying construct that might explain, why a subset of people with FND might have a predilection for caretaking, or, kind of those go, do, and, be there for everyone, regardless of what their designated job is, right? Healthcare is an easy designation for that, but I wonder if there's plenty of other people who work non-healthcare jobs, but actually have that more healthcare oriented mindset where they're the caregiver in their family role, bringing in, more of that biopsychosocial model of within their family system. Are they in that caregiving role, whether they're exposed to neurologic symptoms or not, versus if there's some factor of high caregiving and the high caregiving burden that often, especially women, are put in, right? From a psychosocial context within the family, it's often the women who are doing the caregiving role, which is often like being the nurse to the whole family. And wondering if there'd be a way to look at that, and if that might also explain some of it. But I think it's a wonderful thing to consider, and teasing apart, especially for the higher prevalence rates in women, what's happening there, and why is that the case? And is it societally influenced, and can that be adjusted, or is it biologically driven? My gut would say maybe it's a little more society, the caregiving role of women, but perhaps it's both. I don't know. On that note, though, another piece that I think you and I had chatted about briefly before was as it relates to your neuroscience work. There's certain constructs or constraints also within studying more of a neuroscience perspective and FND, and what you've encountered as far as what you've enjoyed about studying FND from a neuroscience perspective, any limitations you currently see from studying FND from a neuroscience perspective.
Yeah, I guess like one of the difficulties is clearly like also like this heterogeneity that you always see among the multiple diverse patients that you have, because there is like so many different kind of symptoms and like comorbidities. So it's like always difficult, the decision on how to treat that. So for example, you have a lot of psychiatric comorbidities, depression and anxiety. So how do you treat that? How can you find the actual effect of FND? So what is actually caused, or what is related to FND, or what is more related to like other underlying pathologies? And surely also like with the different symptoms that you can encounter is like, do you want to treat it as like one FND, so such as we did it like in our research group, or do you want to study like the subtypes individually? And I guess like both is right and both is also important. And particularly in our case, we worked really transdiagnostically. So we really just included every FND patient that had like a pure FND, so no underlying major neurological diseases or disorders. And we kind of looked at it like to identify what's like the underlying commonality among all these patients. And I quite like this kind of approach, but I have to say now we also started, as we have like a really big sample of patients now, that we can actually also start looking into subtypes, and we can clearly see there are like also differences, but there is also like the common signal that we can detect in all the patients. So yeah, I guess the heterogeneity of this group is still like something that many research groups struggle with. But also that's something that I think is also interesting, like on how different research groups actually tackle that kind of limitation, if you can actually call it a limitation. I guess other parts that are also kind of difficult nowadays, or what I would like to see to move forward is, for example, a lot of research in FND is still based on like the functional magnetic resonance imaging, right? So where we can actually very clearly see a signal. So there is something in the brain in these patients. So it's not just like imagination or just in your head, as some doctors like to say. It's like, sadly, that is, for example, fMRI particularly, it's nowadays mostly used for research. And I guess it would be such a strong tool if there would be at some point ways of actually like translating it from bench to bedside, because it would also like give another dimension to, for example, or I guess it would help the diagnostic process also if we can have something, again, objective, imaging based. So as mentioned, so the signal is there. We just have to find out how we can make use of it clinically. And I guess that would be still a limitation, but I guess we should just continue moving forward in that direction. Yeah.
Yeah, it sounds like what you're advocating for is a translational from bench, as you said, to clinic and bedside in terms of our ability to, for an individual, capture differences in brain functioning, which presently we're currently limited from a clinical perspective to differences in structure, more or less.
Exactly.
EEG captures a little bit, but we still consider epilepsy a structural kind of issue where there's an electrographic storm within the brain that doesn't differentiate, right? The defining feature of epilepsy versus FND is, there's no electrographic change, which means it's not sensitive to the underlying brain processes at an individual level for individuals with FND. Yeah, that would be delightful. And I had that conversation with my patients all the time of current clinical tests can only show us, basically broad structural issues. At a connectivity level, we can see the connectivity changes in samples of research people where it's groups of people using different modalities that are not available for clinical use. And yeah, it would be great to not be able to have that disclaimer. Thank you so much. Well, I think this has been a delightful conversation. I've really enjoyed just hearing your perspectives and the way you're thinking about stress within the brain and how you think about that as it relates to FND, which I think is just such a crucial piece of the puzzle for people with FND. Thank you so much for all your research and your time. And I look forward to hearing and seeing more things that you and your lab do.
Thank you. It was really a pleasure to be here with you. And thanks for the invite.
And that concludes this episode's podcast, and we hope you join us again next time. As promised, here's a code for 50% off of the first year membership to FNDS for our listeners. Code FNDS003.